time toxicity in myeloma is very real. The idea that our patients, particularly in the relapse setting, spend much more time in clinic than even they might expect, and certainly more than we realize if you include time spent scheduling, coming in, blood work, IVIg, et cetera. And so what I'm really happy to see is that the whole bispecific field, part of the reason I'm saying everything I'm saying right now will be outdated 2 years from now, is we're all jumping towards how do we de-escalate treatment? How do we get the drug started more quickly for patients and spend less time in the hospital? And they're all investigating that. And so you'll see different variations between them in terms of how many hours of inpatient observation have historically been required after each step-up dose. The step-up dose is kind of the priming dose to just make sure to mitigate the risk of cytokine release syndrome or CRS. That varies between the drugs. How quickly you can get to every 2-week dosing per the trials varies between the drugs. For teclistamab right now, it's 6 months of remaining in a CR, a sustained CR. For other drugs, it's more like after 4 months or after 6 months. Linvo has evidence and elranatamab going out to every 4 weeks. But the field is rapidly evolving. We've also published data in the real world setting. People de-escalate bispecifics much faster than the 6-month mark. I certainly do the same in my practice because, again, people have time toxicity, people have infections, and it makes sense to de-escalate them to once a month. You don't have as many side effects and not as much time in clinic. And so I think basically we're seeing that evolve across all the products, and I think that will continue to evolve. And our hope, and I briefly touched on this, was as of right now, everything I've said is still predicated on the idea that patients stay on the bispecifics forever, basically until progression. I just said duration of response can be 2 years. That's 2 years, again, by the book would be 2 years coming in every single week for therapy, which sounds crazy. So we're de-escalating to once a month, et cetera. But there are studies ongoing of quarterly dosing every 3 months, or a very intriguing study, the LimitTech study being run at Penn, of time limited, like 6 to 9 months of treatment, and then just stop and see what happens and observe these patients very carefully. And I think that's where the future is headed. If we can do that, I think that will be even more fascinating in terms of the broader discussion, which I didn't particularly focus on. I focused on bispecifics, but bispecific versus CAR T. CAR T therapy is a little bit tougher logistically on the front end to get situated, but on the back end, it's a one-time infusion, and patients typically don't need to come in more than once a month for blood work, maybe IVIg and so forth. The bispecifics a little bit tougher, as we said, more time toxicity. But if it's 6 to 9 months of therapy, then you're done. I think that actually might equalize the playing field here. And you may see some patients say, look, CAR T has some scary toxicities or is too impractical for me. Let's go with the bispecific instead. And I think it'll be really interesting to see how that goes.